Hello, I'm Mike Zaretsky, maternal fetal medicine and medical director of the Colorado Fetal Care Center, and I'm here with...
I'm Dr. Cristina Wood. I'm the medical director for OB anesthesia at the Colorado Fetal Care Center. Thanks for joining us today, and we're going to talk about common questions that providers and patients have about pain management during labor.
Okay, Cristina, what is the benefit of a medicated birth versus a natural birth?
So whatever journey the patients prefer for pain management is what we want to support. There's not a correct answer here. So unmedicated births, medicated births are perfectly safe either way. It just depends what the preference is. Some advantages, though, to having good pain control during labor are better bonding with the newborn after delivery because that postpartum depression or postpartum blues is significantly reduced with good pain management. Another option, too, of having a labor epidural, if you have to have an operative delivery like a cesarean, it is a chance that we can use that epidural and keep you awake during the procedure is an advantage as well. So there's really not a right answer. It's really just whatever the patients prefer.
Okay, so what are the real risks to an epidural?
So epidurals are very safe, and we do lots of them. We know across the country about 75% or more of laboring women get epidurals, so we have lots of data on this. The scary things that we tell patients about are like bleeding in the back, infection, permanent nerve damage are really rare, about 1 in 300,000 risk. Things that are more common, though, you have about a 1% risk of getting a headache from an epidural. Lots of ways to treat that should that happen. And you can get a little itchy from the epidural. Again, medications can counteract those effects without any issue to mom or baby. The blood pressure is something we do have to monitor when you have the epidural because we do cause a partial sympathectomy, and so that blood pressure can drop a bit. So moms do need to wear a blood pressure cuff so we can keep them safe. Things that epidurals do not contribute to are increased cesarean section risk or increased vacuum or forceps delivery. And that's something that people see out there in the literature, but we've studied that pretty extensively and can confidently tell patients that.
So Cristina, when can a patient get an epidural? Do you have to wait till the cervical dilation gets to a certain point?
You will find that if you Google search, but that is actually a complete myth. So one of my good colleagues out at Northwestern did a study showing that there is never too early for an epidural. So it's not going to prolong labor either first or second stage. Certainly how we do epidurals now and over the past 15 years or so, we do not increase that length of labor and there's no risk of getting it too early. Some women decide they want to get that at the very beginning of labor and other women wait until they're much more uncomfortable and further along. Again, not a right answer. A right answer is the right answer for the patient, but there's no risk in an early epidural.
So at any point in labor where it's too late to get an epidural?
It's a great question. So we do advise moms that once they're actively pushing the baby out for delivery during second stage, it's really difficult for us to get them in a safe position to place an epidural. So we advise them that even up through complete cervical dilation, we're happy to place that epidural. But once they're ready to push, it's a bit too late. I also should note that there are just patients that cannot have an epidural at any time. So patients that have certain coagulation issues are on anticoagulants, may have things that cause increased cranial pressure, or have congenital malformations like spina bifida. So it's always good to talk with your anesthesia provider so they can advise the patient the safest way to proceed. But really only a too late is once they're actively delivering the baby.
Okay, what about trial of labor after cesarean delivery or VBAC? Is there any concern of the use or non-use of an epidural in that setting?
There used to be data that they thought that labor epidurals would mask a uterine rupture or dehiscence. We now know that's absolutely not true. And labor epidurals not only give great pain relief, but they're not strong enough to completely mask any problems along those lines. But we recommend most of our VBAC patients or TOLAC patients receive an epidural during labor if they're interested in that. Because if they do have to have another cesarean delivery, this will increase the likelihood of them staying awake in an urgent or emergent situation during that cesarean, in addition to the pain relief. But it's perfectly safe for TOLAC patients to have a labor epidural.
So Cristina, there's a rumor out there that the medical profession wants to prevent women from having a natural childbirth. What's your opinion on that?
I've definitely heard comments along those lines, and I will say that, again, we just want to support the mom's journey. So if her desire is to have a natural childbirth, that's perfectly safe. One of the things that I mentioned earlier is not having that good pain control, however you achieve that during labor, can definitely affect your postpartum mood and your interaction with your neonate. So whether that is using laughing gas or using IV narcotics or using an epidural for pain relief or using unmedicated options like aromatherapy and massage, all of those are perfectly appropriate to use. We want moms to go ahead and do what they feel comfortable with, and we're just here to support that. So we don't support one option over another. All we want is healthy mom, healthy baby.
If a patient is opting for natural childbirth and their blood pressure starts increasing, is an epidural warranted to reduce the blood pressure?
That's a great question. So epidurals definitely do reduce blood pressure, but we would never recommend that as the primary intervention for hypertensive disorders in pregnancy. One of the things when women have hypertension or preeclampsia with severe features or even without severe features, you can see a drop in their platelets. So thrombocytopenia, when that gets significant enough, can actually be a contraindication to an epidural. So when women have these hypertensive disorders, we do counsel them if they're thinking of an epidural, we want to make sure we do it early enough before we might see those laboratory changes. And while it will decrease their blood pressure with a sympathectomy, we just would never recommend that as primary treatment.
Is there any problems with the mother bonding with the child after having an epidural?
Not at all, and we encourage that. So the epidural, all of the medications stay in the woman's back. So nothing is getting systemically in any clinical significant concentrations. So nothing is affecting the baby or affecting the mother from a sedated standpoint or an altered standpoint. So she's able to interact and bond immediately after birth. She's awake and aware of the delivery, and if her pain is adequately controlled, she may not be too exhausted. She may not be too traumatized, maybe a strong word, but not too frazzled after the delivery with an epidural with good pain control. So bonding with her infant is very easy and appropriate and encouraged.
On the same topic, is it problematic for the mother to have skin-to-skin contact and breastfeed with an epidural in place?
Another great question. We've done a lot of research on breastfeeding and neuraxial analgesia or labor epidurals, and we've found that there is no issue with breastfeeding, with latching, with breast milk production, with any of that. Again, because those epidural medications stay in your back and are not systemically absorbed to affect any of that interaction. So we encourage breastfeeding as soon as moms can after delivery, or at least pumping to stimulate that milk production, and having an epidural will not affect that.
Why would a patient be interested in the SOAP Center of Excellence designation that the center has?
The SOAP Center of Excellence designation stands for Society of Obstetric Anesthesia and Perinatology, and the Center of Excellence designation means that we have met criteria, including the most evidence-based protocols for obstetric anesthesia, risk stratifying our patients for hemorrhage risk, providing all kinds of interventions to get them ambulating and eating soon after their deliveries, just to assist in their recovery and their bonding with their neonate. In addition, the center has to have specialty trained anesthesiologists providing this care. So if you're delivering at a center of excellence, you know that that center has the most up-to-date protocols and up-to-date providers to take good care of you.
What can be done if the epidural is not working well?
Great question. First thing is we want to know about it. So as an obstetric provider, if you're seeing a patient that is not having good pain control with an epidural, please be sure your anesthesia service is notified very quickly. Labor is incredibly intense, but it is relatively short, and so we want to make sure that we're getting good pain control. There's a variety of things we can do to optimize the situation. We can adjust the catheter. We can adjust the medication going through the catheter. And if we need to, we can replace it. We know somewhere between 3 to 7% of labor epidurals need to be adjusted or replaced. So it happens, and like I said, we really want to know about it because we don't want our moms suffering. Sometimes we hear that the moms have said after delivery they thought this was the best that it could get, meaning they only maybe had one-sided coverage with labor pain management, and we can do much better than that. So absolutely we can adjust or replace if needed, but we need to know.
So a timely issue is COVID. Does this have any effect on epidural placement?
That's another great question, and things we didn't know when COVID first came out. We've done, again, lots of research on this, and there is no reason that a COVID-positive patient mom cannot have an epidural. So we routinely place those in COVID-positive patients. But one of the derangements that we see with COVID is thrombocytopenia or even full coagulopathy. So we do have to assess those parameters in those patients prior to placing the epidural to make sure it's safe, but there's absolutely no reason that they can't have that.
If you require general anesthesia for your delivery, is there any issues with breastfeeding, such as the need to pump and dump?
Great topic. Lots of questions about that, and really important for moms. So if you need general anesthesia for any reason, including delivery of your baby, you do not need to pump and dump after you wake up. A variety of societies have weighed in on this, and a lot of research has been done on medications in breast milk. We find that there is not a sufficient amount of any of our anesthetic medications found in breast milk that would affect the infant. So we recommend moms to go ahead and breastfeed as soon as they're awake and aware enough to hold their baby. Please don't waste any of that wonderful breast milk. We do not want you pumping and dumping that.
Thank you for joining us today. And Cristina, that was great information about anesthesia in labor. Hopefully this is great information for your practice and your patients.
Thank you, Mike, for having me here, and it was my pleasure to share this information with you all. If you would like any more information, please visit our website or contact our center. Thank you.